This is a seminar sponsored by Hologic and deals with issues around screening. And if anything we've learned in these meetings is that screening is a quite complex social and individual and technological decision-making process in which many things have a shadow of variability, and the final results need to be carefully controlled and carefully examined. It is also a pleasure that very recently the RNA assays of the Aptima system have been adopted as validated for primary screening. Still some issues, there are always some issues around certain aspects of the procedures, but essentially we welcome another one to the armamentarium that we have for screening programs. The session today will have three speakers. Thomas Ivner, that is long-term scientist in the technology for screening, and he will update us on the trials that have led to the recognition of the value of the mRNA assays. Then we have Dr. Mark Fisher, who will introduce another aspect that has been relatively neglected in our meetings recently, which is the capacity of the digital technology and the e-learning processes for diagnostics in screening. And we finally have another speaker, Dr. Marcial García Rojo from Spain, who will link the capacity of the new technologies and the new projects to organize de novo screening programs in the southern part of Spain.
Thank you very much, Javier. Welcome everybody here. It's really a pleasure to be here today and to talk about the update on longitudinal performance and real-life data of HPV messenger RNA assay. These are my conflict of interests. And the WHO has a while ago announced a global strategy towards the elimination of cervical cancer with a really challenging vision until 2030 to reach a threshold of less than 4 cases per 100,000 women years all over the world. Really challenging. And they want to do this by screening at least 70% of women with a high precision test twice in lifetime, and to follow up 90% of women that have suspicious findings, and also by vaccinating young girls, coverage of 90% by 15 years of age. And they said with a high precision test. And what is a high precision test? And they are actually recommended to use nucleic acid amplification test, NAAT, for DNA, as you can see here, but also for messenger RNA. In the next minutes, I would like to show you some data why they decided to do so. First of all, when you look what potentially can be detected by an HPV DNA test, this is clearly a living infected cell that contains the virus, where the viral genome is replicating, but also in dead cells where DNA is still left over, it can be picked up, but you can also pick up viral particles outside of a cell with a DNA test if you have the respective pre-analytics. The RNA test, however, only can detect RNA in living infected cells where DNA of the viral genome is present, that is transcribed into the RNA. And the messenger RNA test we are speaking here about is detecting the viral messenger RNA of the viral oncogenes E6 and E7, and this RNA is actually present in almost all of the multicistronic RNAs that are produced from the viral genome, from the DNA. Now, however, we not only have single cells that are infected, we have cells that are in a tissue, in the epithelium, that are infected. And what you can see here in this graph here, which is a simplified sketch of the stratified epithelium, the non-infected epithelium, then we have the possibility of having latent infections. And what you see here, the stars in yellow show the presence of viral DNA, and the size of the star actually is a symbol for the amount of the viral DNA. The purple cells are cells that harbor the viral genome and have messenger RNA and becoming abnormal. And what you see here, the latent infection, we don't want to even pick up, we don't want to know about because it's clinically irrelevant. But when we look now at these different stages of the precancers, the cervical intraepithelial neoplasia, grade 1, 2, and 3, there's a big difference between grade 1 and grade 2 or 3. Because in grade 1, we still have, as you can see in the histological picture here, histopathological slide, we still have almost normal epithelium that has a capacity for fully terminal differentiation. And this is a requirement for the completion of the viral life cycle to produce actually new particles. Because in a stratified epithelium that is able to differentiate, as you can see here, in the upper layers of the epithelium, the viral genome amplificates to few thousand copies per cell, and these copies are then packaged into viral particles and are released from the epithelium. So you can see in the CRN1 here, you have in relation, when you compare DNA versus RNA, you have much more DNA in a CRN1 than RNA, which is actually here, the purple cells that express usual amounts throughout the epithelium, but because of this, the ratio of DNA, RNA is in favor for DNA. So that's why the likelihood that this lesion is picked up by a DNA test is actually higher than it's picked up by an RNA test. If you have ongoing progression to CRN2 and 3, we are losing the capacity of the epithelium to differentiate, meaning you have no more any possibility for the virus to replicate. We talk about an abortive infection, no production of viral particles any longer, and at the same time, the risk increases that the viral genome integrates into the host chromosome. And so we have, during the process of this progression to cancer, we have more cells in the epithelium that are abnormal, all have RNA. We have less DNA because there is no amplification, there's only replication, and there's also integration. This is very important to keep in mind. We performed quite a while ago in Germany a study, the so-called GAST trial, where we compared out of a single vial from liquid-based cytology, the RNA test, the aptamer, with a hybrid capture DNA test. Cytology was performed out of the slide, and if you had a positive result for an HPV test, we did also the genotyping out of that. And in this cohort, we recruited in 3 centers in Germany, 10,000 women aged 30 to 60 years. Exclusion criteria are shown here, and we aimed actually to follow up women that are positive in any one of the tests, either cytology or 1 or 2 of the HPV tests. Within 8 weeks, they were sent to colposcopy. And also we had a control group where 5% of women that were tested negative by all tests also were sent to colposcopy. Interestingly, we also have a longitudinal component in this study where we followed up positive women that did not have any therapy after a positive finding for up to 5 to 6 years, and we also re-invited the triple negative group after 5 to 6 years. When we look at the cross-sectional data, and this is shown here from 0 to 100% sensitivity, and here at the x-axis 1 minus specificity, you can see sensitivity is the same for both tests, for the RNA-based test aptamer and the DNA-based test hybrid capture. And there's a slightly higher specificity, but in general, comparable sensitivities and specificities for CIN3+, I have to say. And the longitudinal component was done in the way like the co-testing is performed. So all the women that were triple negative in all tests, they were re-invited after 5 years and for having again both tests, DNA, RNA, and cytology. And all those women that were positive in one of those tests had a yearly follow-up till they were either treated or, again, the next year they had the next follow-up also for up to 5 to 6 years. And again, colposcopy was a discriminator at the end for performing a therapy in addition to pathology or not. And when I show you the raw data here, 10,000 women, so most of them were negative in all tests. We aimed to recruit 4,000 women after 5 years. Actually, 3,295 women came in, and we found only 4 CIN3 in this group, meaning that having this co-testing with DNA or RNA plus cytology has a very high safety that women will not develop any high-grade lesions. Now, the women that were positive in any tests and were not treated, 606 were eligible, and out of that, we had a small group of women that were cytology positive and HPV negative at baseline, and we had not a single case of CIN2 or higher in that group. Many more were in the group that were cytology negative and HPV positive at baseline. We had here 18 CIN3, but this was the largest group. And in the group where both tests were positive, we had 8 CIN3. Now, this does not show you the performance of the individual test. This is shown in the next slide, where we looked actually for the cumulative risk for CIN3 over time from 0 to 6 years after a negative baseline result. And you can see here, the red line is HARP capture, blue line is Aptima, and you see no difference in the cumulative incidence rate of those women that were tested either positive by DNA or by RNA at baseline over time in comparison to cytology that was higher. And this increase here comes actually from the triple negative group, because in the positive ones we had almost no cases in years 3 and 4. Now, this was for 6 years. And there is now an interesting study has been published from Canada, the Focal trial, where they had a follow-up of 10 years actually of women. They had a different design. They had 25,000 women in 3 arms, a control arm with 9,500 women, where they had liquid-based cytology only at 24 and 48 months. The intervention arm, which is of interest now here for us, because there they compared the 2 different DNA tests and an RNA test, 9,500 women. The HPV test was at baseline, and if the result was negative, the next follow-up was after 48 months, and they also had a safety arm where they had HPV at baseline and liquid-based cytology at 24 months. So out of these 9,509 women, where they had either hybrid capture, Cobas-Roche, or hybrid capture versus Cobas and Aptima, there was clearly seen that there were fewer women positive in the RNA test at baseline than with the Cobas test, and the long-term risk for CIN3 or 2 was comparable for both. And this is shown in these Kaplan-Meier curves. Again, in the first 4 years, there was no follow-up after a negative DNA or RNA test. And what you can see here on this side, this is the cumulative incidence rate, either for women that were negative by the hybrid capture test, the red curve, or the Cobas test, and follow-up started after month 48. And you see there is no difference between those tests. And this is of interest because the hybrid capture test has no cellularity control, as you know, versus the Cobas has, and obviously this doesn't make any difference. And when they now did the same comparison for the 2 DNA tests with the RNA test, again, all the confidence intervals were completely overlapping. So there was no difference in the outcome. Very interestingly, recently, there were the data published of the English screening pilot, where they had 2 screening rounds. And because of the sentinel side, some of them used the Aptima test, some of them used the Apple test, some of them used the Cobas test. So it was possible now to make a comparison in a real life scenario between the performance of these tests. In total, the whole cohort was 1.1 million, but the women here included from 24 to 59 were about 300,000. And when you now look for the detection rates for CIN3 plus per 1,000 women screened, either by the Aptima, by the real-time Abbott, or by the Cobas-Roche assay, you see there are no differences in the CIN3 detection rates if the women, regardless with what tests they were tested. Interestingly, in the second screening round, we observed what we know already. There is a dramatic reduction in the incidence of CIN3, because all the women that have been overlooked before are fished out actually, and there's only little left. But again, no difference in the detection rate for CIN3 between the RNA test or the both DNA tests. Very interestingly, this study also looked at the appearance of interval cancers between the first and the second screening round, which is shown here for the Cobas in real time together versus the Aptima. So cumulative incidence rate of interval cancer after negative screening test in the first round, and those cancers detected between the first and second round. And again, you see very low, very few interval cancers per 100,000 women years here by the Aptima versus real-time or Cobas or combined, and you see the hazard here is 0.51. clearly no indication that you have more interval cancers if you use an RNA-based test at the screening than if you use a DNA test. Maybe even the other direction, but numbers are really low. There was also a meta-analysis published that did not include these data because they were published more or less at the same time by Mark Arbin. And when he compared the different studies that were published on the Aptima compared to hybrid capture, relative sensitivity and specificity, I can make it short, you don't see any difference, slight increased specificity here. And these are the numbers for CIN3 plus for Aptima. And the specificity, and what Mark Arbin concluded that Aptima could be accepted for primary cervical cancer screening on clinician-collected cervical samples at intervals of about 5 years, and later on he published even together with Karen Canfell after looking at the data from the English pilot that the Aptima is similar sensitive but more specific for CIN2+, and that the findings from Mateka Rebol broadly accord with his meta-analysis. And lastly, there was an interesting systematic review and network meta-analysis recently published by a Japanese group, first author Terasawa, where they looked at combinations of the different screening methods. For example, PCR combined with the link variable and ASCUS in comparison to, for example, the link variable or ASCUS. And the size of the circles here indicate the size of the groups. In total, it was 168,000 women, 28 prospective studies included here. And I don't want to go into detail because the table is complicated, but it shows you when you combine in a screening algorithm in the decision tree the standalone tests with the OR variable, you gain in sensitivity, but you lose in specificity. And if you do the other way around, if you have as a variable and, you lose sensitivity and you gain a lot in specificity. And this is an interesting implication if you think about a triage test after a first positive test, where you would probably like to go for an OR variable because you would like to have the highest sensitivity, and at that time you would not really be interested in the specificity because you want to know what's going on. And there are not so many women actually. And because the table is really complicated, I also show you here the ROC curves. They show for the standalone tests, no surprise. It's known that that cytology, regardless of the threshold, is higher specific but less sensitive than the HPV DNA tests. And when you look for the confidence interval cloud of the messenger RNA, actually it seems to bridge here. When you look for the combinations of hybrid capture with either OR or PCR, with the OR variable, you always have higher sensitivity, and if you use the AND variable, you gain in specificity, but you lose sensitivity. And when you do the same for the messenger RNA, it seems like visually here that you have a shift to the left side in the direction of the sensitivity, indicating again slightly increased specificity regardless what you do. So to sum this up, sensitivity of DNA and messenger RNA tests both have a high sensitivity. Specificity is good. Both tests a little bit better for the messenger RNA. The referral rate is because of that, because of the lower detection rate at the beginning, is higher for the DNA tests and lower for the messenger RNA, which makes it more cost efficient, as has been shown in a number of trials, and the negative predictive value over 10 years is in both cases really high. So the summary, I would like to say the detection of viral messenger RNA is a proxy for the detection of an active viral infection, and it's also a proxy for the presence of the HPV DNA, because there would be no RNA if you have no DNA. And regardless of the study design, you always find similar sensitivities of Aptima and hybrid capture for CIN2 and 3+, accompanied by a higher specificity. And we need to think about, when the screening intervals are lengthened to 3 to 5 and even to 10 years, that we need new validation criteria for the longitudinal data with the CIN2+ endpoint for HPV screening tests. And published data so far are available over 10 years for hybrid capture for COBAS, for the real-time assay, and for the Aptima. And the longitudinal studies, including Aptima, hybrid capture, and COBAS, show same long-term risk or longitudinal sensitivity over 7 to 10 years for the Aptima assay. And even the real world data from UK clearly show that the Aptima test can be used in cervical cancer screening with intervals of 5 years or even longer. And the lower referral rates, due to the slightly higher specificity, it means that the test is more cost efficient, and we don't have more interval cancers than with DNA-based tests. And I think the lack of the cellularity control is also not an argument, as you can see from the focal trial. And with this, I would like to thank my collaborators here in the different studies. A special thanks to Uli Petri, who unfortunately passed away 2 years ago, for the long-standing collaboration with all women, all gynecologists who participated. And I would like to thank you for your attention. Thank you.
I would like to introduce some thoughts on co-testing and also show you our switching to digital cytology with the Hologic Genius digital system. I have had some travel expenses reimbursed by Hologic in the past. So my lab is monopolistic for the whole country of Luxembourg. So in 2022, we had a total of 138,000 pap smears and around 61,000 HPV tests. Along that, we had 33,000 tests for sexually transmitted infections, chlamydia, trachomatis, Neisseria gonorrhea, and mycoplasma genitalium. The lab is fully accredited for gynecological cytology as well as for ancillary testing for HPV and STIs. And for the moment in Luxembourg, you have a recommendation for co-testing dating from 2017, but there is no call recall system in place. So the gynecologists are doing more and more prescribing an HPV test as a co-test alongside a pap smear. So several thoughts about why should we stick with cytology and especially also digital, going to digital cytology, as the general tendency is to go to primary HPV testing. Well, I think there will be a future for, especially for high-performance cytology, but for cytology, and this for several reasons. There is a reflex control, there is need for a reflex control test for HPV-positive patients, and this is cytology for the moment. And the existence of generally advanced abnormalities that have a low viral load so that they will not be detected by routine HPV tests. We know that around, in the literature, there are the figures that 8 to 9% of SIN2 plus lesions will be negative for HPV testing, as well as around 17% of invasive cancer cases. And several studies on which I will pass rapidly will show that. The POBASCAM study had 9.4% of SIN2 plus, which were HPV negative, 5.7% of SIN3 plus negative, and 16% of invasive cancers were HPV negative. A study from blood in 2015 showed 6% of SIN3 plus lesions negative, 19% of invasive cancers negative. A study in 18 showed 7.2% of SIN3 plus negative and 13% of invasive cervical carcinomas that were preceded by a negative HPV test. A study from Germany, from Frankfurt last year showed that, I'm quoting, co-testing from the age of 35 in a large standard population could lead to improvements in the prevention of cervical cancer. LBC is superior to conventional cytology. Co-testing has a higher sensitivity and specificity compared to cytology only. They had a low prevalence of HPV positivity, 6.4%. They had a very high percentage of HPV negative cancer cases, 29%. And they had 3.85% of HPV negative HIC cases. So co-testing has, in my mind, but I'm a pathologist, I'm excusing for that, has a huge advantage over primary HPV testing because of these HPV negative advanced abnormalities. This might in the future get less attention than needed because of a drastic drop that is expected to happen because of HPV vaccination. In immigration countries like Luxembourg this problem will remain critical because you have a lot of patients coming as adults and you don't have their history, their complete history, their clinical history. So, digital cytology, it starts with the thin prep vial from which you are producing a slide, a thin prep, liquid-based slide, which you put then in the scanner of the system, and the algorithm will choose a certain number of spots which you can see on your review station number 5. The review station will show you on the left-hand side 5 rows of different subjects of remarkable positions, remarkable images. And on the right-hand side, a customable image where you can put every small tile image in, or you can also walk around on the slide. So in Luxembourg, we started in 2021. We had an installation of a smaller version of the system, with the objective of doing the verification process and also the training of the pathologists and cytotechnicians. We trained 12 cytotechnologists and 2 pathologists, and a 3rd pathologist was trained afterwards last year. We did the method verification in December 21, and we started. And we had to introduce, because in Luxembourg it is mandatory to have an accreditation on HPV as well as on cytology, we had to introduce the dossier to the Luxembourgish accreditation body, OLAS, prior to use of digital cytology in routine diagnostics. We also looked at the reproducibility between the 3 scanners. For that, we compared 40 cases which we passed on each of these our 3 scanners, and 2 cytologists reviewed the case. This led to similar diagnosis in all 40 cases in the 3 scanners. The same images were in the tiles, although not necessarily in the same order. And for that reason, I think you should, it is necessary, to my opinion, to open always the 2nd row in order not to lose information about what the system has collected. So on June 8, we were signified that we could use the system under scope. So we started the change for 100% of digital cytology on the 4th of July 2022. And optical microscopy is only an alternative for the slides that the system rejects, which are not very many, it's under 1%. This is an image of our installation with the 3 scanners. And this is the review stations at the desks of the cytotechnicians. So, first, the global 2022 statistics when comparing them to those of 21. And then we will have statistics for the first half of the year, liquid-based with imager, as opposed to the second half, liquid-based with Genius Digit. Here you have the results in 21 and 22, and you see that you have a total of, in 21, with the imager you had a total of 7.71 positive cases, as opposed to 8.55 in 2022. So we had an increase, a clear increase. These are now, this is a chart showing you starting in 2010 and going until 2022, the total number of positive cases. You see that with the conventional period, we were around 2%. Then we had a peak when changing to, to liquid-based, and we had an increase afterwards. More interestingly is the high-SIL cases. You had a very strong peak after conversion to liquid-based, and then as a harvesting phenomenon, cases went down and remained stable, although higher than in conventional times. So the figures for 22 are, with half of the year being on digital cytology, are consistent with those from the previous years and remain coherent when comparing the different diagnostic categories with each other. So my conclusion is that you can do at one moment 100% switch to digital cytology without having major issues coming in your diagnostics. Here is the year 2022, and we compare the imager period, the first half of the year, to the digital period, the second half. You see that we have an increase in the total percentage of positive cases from 7.4 to 9.71. And you see also that you have high-SIL and SKH remaining almost the same, but you have an increase in ASCUS, and you have an increase in low-SIL. So in each arm you have roughly 70,000 cases tested. The figures are the same for high-SIL and increased for low-SIL and ASCUS. So the lack of increase in high-grade lesions must also be seen in the specific context of Luxembourg with a very small target population of, let's say, 200,000 individuals. So the risk for cancer is not that high in such a small population. As there are generally no histological controls for low-grade lesions or for ASCUS, we compared the HPV positivity rates for each of the two categories with the ones of the previous years. And in the previous years, as you see here, we had HPV positivity rates for ASCUS around 35 to 40%, for low-SIL at 65, 70%, and for high-SIL around 90%. And in 2022, globally, we had for ASCUS 35%, for low-SIL 65%, and for high-SIL 90%. And here are the charts for both half years separated. You see that for ASCUS, low-SIL, and also SKH and high-SIL, the images are completely similar and can be superposed. So the HPV positivity ratio in each diagnostic category remains similar as compared to the previous years. So the increase in ASCUS and low-SIL cases is thus to be considered an increased detection of relevant cases and not an increase in diagnostic noise. And of course, we'll have to see what happens in the future to see if the high-grade lesions are also going up or staying similar as for now. One small issue is probably with the unsatisfactory rates. We went up from 1.22 to 1.97. The system has an approximate cell count function, and this function may underestimate cell counts, particularly when smears are atrophic or hemorrhagic or inflammatory. This is not a diagnostic issue in itself, because you can manually put the system in 5 times magnification and evaluate the slide like before. So some points very quickly. The switch to digital in our lab went very, very smooth, and everybody grew very rapidly confident with the system. The gain of time is spectacular. I would say you do one case in under 1 minute, more or less. This is obviously very fantastic, and you get also less tired. However, a complicated case will remain a complicated case even in digital cytology. Very important, I think, what helps a lot is the fact that you see all the cases, all the tiles, all the images that the system has selected at the same moment. This helps you a lot in your diagnostic choice. You can, the system is great for discussion of cases in the team because you can do it on the screen. And it's also easy to take pictures. The system comes with extensive statistical reports, number of slides reviewed by any given member of the team, number of errors, number of slides not reviewed, etc., etc. So this is fine if you are accredited and if you need those kind of statistics. And the complete absence of patient data in the system, because you have only a referral number and the pictures, so you don't have any risk of data protection issue. So to summarize, you have here from Hologic, you have from the ThinPrep file, which is in the middle of the slide, you have two things that you can do at the same time. You have on the left-hand side processing the slide and imaging it and reviewing it for cytology on the Genius Digital, but you can also, of course, process it for moleculars, for the Optima HPV test, or for specific tests for sexually transmitted infections. General conclusion, I think cytology, and especially digital cytology, can be instrumental in further reducing the burden of cervical cancer in the general population. Cytology has an added value when compared to primary HPV testing due to existence of generally advanced HPV negative lesions. Digital cytology will offer you standardization and rapidity and comfort in combination with the clear benefits coming from LBC when you compare it to conventional cytology. And in comparison with microscopy on LBC, digital cytology comes with yet a higher rate of low-grade lesion detection. With that, I would like to thank you for your attention. Thank you.
Thank you, Mr. Chairman. I would like to thank Hologic for inviting me to this symposium. It's the only conflict of interest that I can declare. And I would like to show you the combination of all these two technologies, digital cytology and RNA testing, in our change of the screening program in Andalusia that is moving from opportunistic to population-based. In our lab, we have been working for many years now, from almost 20 years, in digital pathology, and we are getting rid of the microscope. But it is true, cytology was a problem, it was difficult, but now technology, as Dr. Fischer has just shown, has evolved and is allowing us also to digitize cytology. So what I will explain is the consequences of this possibility for a screening program. And one of the first consequences is that first, if you are able to digitize, then you can use artificial intelligence. And it's coming up in many areas in biomedical field. And one of them is in medical imaging. It is helping us a lot in histopathology, but also it is really helping also in cytopathology. Also because it is making us easier to identify abnormal cells in a much quicker way, as we have just shown, and also because it opens the possibility that in those countries, for instance, with low middle incomes, where you are not able to have cytotechnicians, you are not able to have all the technology, all you have to do is to scan those images, to send them to a remote place, and they will interpret and they will diagnose those images. That means lowering the training needs, for instance, because cytotechnicians can be, or pathologists can be in a remote place. With these ideas, we try to how we can implement this in a screening program like ours. And we were very interested because if you review the literature, all the results that we are obtaining on artificial intelligence, specifically in one area of artificial intelligence, which is deep learning. For instance, I'm only going to show this meta-analysis in which they study the impact on cytology, but also on colposcopy imaging. What is the importance of applying artificial intelligence? The main results are, currently, if we collect in this meta-analysis all the results available some years ago, most of the studies were until 2 years ago, it shows the results are not inferior than usual manual review. It is true that some studies are coming up saying that, but you can improve sensitivity, you can improve specificity. It's true, but if we analyze all the in a meta-analysis, it is not demonstrated. What is demonstrated is artificial intelligence is not inferior to manual review, but with a much better performance. And Dr. Fisher has been very clear. We can spend much less time in reviewing those images. And also, it is important that in this study, when we analyze an artificial intelligence papers, to analyze the quality of the data, not only amount, but also the quality of the data that are shown, because there are some discrepancies between some papers. And another important issue is imaging is not alone. If you combine imaging, artificial intelligence in imaging with other biomarkers, and we're talking about HPV, we're talking about P16 and so on, then the results can improve significantly. Okay, in our area, Andalusia is the largest region in Spain, the largest autonomous community in Spain with 8.5 million inhabitants. And this is their target population that we have divided in between 25 and 34 years. And women between the 35 and 65 years is 1.8 million. The situation right now was that we have 39 pathology labs doing the screening. Most of them is based on cytology, and some of them, not too many, are based on HPV testing or combination of the two, but as I said, it's only opportunistic. We are here in Cadiz, right in the south of Spain, and we will focus on the work that we have done in this province of Spain. The general organization of our screening program wants to become population-based, but having in mind that we have to be more efficient than we used to be with these 39 labs. And how to do this? Mainly thanks to the automation. Automation on cytology, automation on HPV testing. So we need to redesign the process. In most of the cases, this means implementing reference center, centralization, but let's see, but because we can make this centralization in some processes, but not in everything. And this is what we will try to explain later. Okay, this is the population. To screen in Cadiz, for instance, is almost 300,000. And for instance, for HPV and also in cytology, as the clinical guidelines that we have currently in Spain will be between the 25 and 34 in 71,000 people, women. Regarding Cadiz, of course, we have to assume the general rules that apply to the new screening program in Andalusia, but thanks to this centralization process, we have defined a modern reference laboratory in which most technical processes are going to take place, but human resources are not going to move. This means that cytotechnicians and pathologists will still be working in the areas that they used to work before. No? And for the technology, we are using liquid-based cytology and Aptima, and I will explain later why we decide to use this RNA testing. So we need to redefine these processes. We need to maintain quality assurance with this managing system, and we also needed to do some training because we are work quite differently with the combination of HPV and digital pathology. Everything changes, and training is very important. The main change is what used to happen is, for instance, in this mountain area of Cadiz, in the Sierra de Cádiz, normally all the specimens used to come to Jerez, but now this is not like that. They are going to all the specimens from the primary care centers are going to a hospital in another town, in San Fernando, in the hospital of San Carlos. And in Gibraltar area will be the same. Normally they used to send all these specimens to Hospital La Línea or to Hospital Algeciras. This is going to change. All primary centers in Cadiz are going to send the specimens. It doesn't matter if they are for cytology or they are for HPV testing. We will follow the current guidelines. All the specimens will go to Hospital San Carlos. This means that only in Hospital San Carlos we will have the technology to prepare digital cytology, to scan digital pathology. So a scanner, one single scanner for the whole province. But the reviewing stations will be where the cytotechnicians and the pathologists are. This means that they don't have to move from Jerez to San Carlos, and specimens or images do not need to move. Only digitally images are going to move from San Carlos to Jerez. The server will be, for instance, the server will, physically, the computer server will be in Cadiz, but everything will happen in another town, in San Carlos, where we have all this technology to prepare the specimens. And the reasons why we selected mRNA is because we show in some papers that it can be, and also we have seen this presentation earlier, more cost effective because it reduces the number of false positive. Having this reduction of false positive, what is the impact on the number of colposcopies, on the number of repeated HPV testing? Quite significant. In fact, I'm showing this paper we made with the theoretical numbers of Spain, and in this cost analysis, we were able to show that compare with other testing, like DNA testing, we can save theoretically more than 40 million euros only in Spain. If we were able to screen all the population. And if we apply this model to Andalusia, this means that we can avoid almost 30,000 colposcopy, and we can avoid unnecessary pap smears, or more than 60,000. And if we go down and we apply this to our province, to Cadiz, this means a reduction of 4,000 colposcopies and almost 10,000 pap smears or cytologies. This is not only in Spain. This cost efficiency or cost analysis studies has been done in many countries, in some other countries, and the figures are quite similar in the reduction of unnecessary colposcopies, but also unnecessary cytologies, DNA testings, and so on. In order to apply what we have seen on our screening program, it was very important that we could make an efficient system. So in order these systems, this digitized system, to be really cost effective, you need to concentrate all the efforts in one single place. It doesn't make sense to have these scanning systems in small hospitals. You really need good numbers, large numbers of slides to make profit, to make these systems really efficient. And the same happens for artificial intelligence that is also integrated in this workflow, in digital cytology solution. The good thing is now with technology, the server, the computer park, can be anywhere. And we decided, for instance, that these machines were going to be in one place, but these machines, this computer, are going to be in another part of the province. And then, as I showed, the reviewing station in a distributed way. So, the slides are not traveling any place. We are receiving the specimens in only one place. These slides are being digitized, and these slides are stored in Hospital San Carlos. They do not move to any. The only thing that moves is the digital images to work as Dr. Fischer has explained. No? So, to summarize these ideas, we will have this primary care distributed all over the province that are sending their specimen to one single place, to this reference unit. In this reference unit, we are doing the accessioning, and we are distributing what is the specimen that needs cytology, or what is the specimen that needs only HPV testing. If cytology is needed, then all slides are being scanned. And these scan slides and also all the information for HPV testing are sent to the cytotechnicians. Cytotechnicians are distributed in 5 hospitals. And then validation is done by pathologists, and one single report collects all the information for when cytology is also available. If a cytology report is needed, then it is integrated with the same information as HPV testing. One more thing is, we are not only including a specimen from the screening programs, I mean the specimens that comes from the primary care center, but also all the specimens that come from gynecology and the follow-up of the patient, or from the radiotherapy, oncology radiotherapy. All these specimens also come into this reference center, and they are in the same pool, in the same workflow that we have shown as the screening. I mean, it doesn't make sense to have HPV testing only for gynecology follow-up in the hospital when we have one single reference center that is able to do so. So my conclusions will be cervical cancer screening based on one side on HPV testing, on other sides on cytology, can be centralized now with this new technology in a reference center. And the idea in Andalusia is having one reference center for one of the provinces. We are 8 provinces, so we will have 5 reference centers. The first one is Cadiz, but only in the technical part, while the interpretational, the diagnosis is still distributed, in our case, in 5 centers. This mixed and distributed center was made only possible thanks to digital pathology. And we really think that artificial intelligence can play an essential role in order to increase, because it is showing up in some recent papers, not only sensitivity, but mainly the objectivity of our diagnosis. So in the future, we think also cytology and digital pathology and artificial intelligence, I agree that it can play an important role in the interpretation of what's happening with HPV testing and in patient follow-up. Thank you so much.
Thank you very much for these presentations. We will now have 10 minutes for questions. If anyone in the audience would like to... Do we have microphones? Yes.
Thank you, Hans Ickenberg, Frankfurt. Question to Dr. Fischer. How can you be happy with such an obviously significant increase in low-SIL and ASCUS cytologic diagnosis without the proof that behind them there will be a significantly higher number of histologically confirmed high-SIL cases? And second question, what do you do to achieve or not to achieve that goal?
So, thank you for your question. For the moment, we have a situation where we have just an increase in ASCUS and low-SIL, but we are maintaining our ratio for HPV positivity. So, as these lesions are generally not treated with biopsy or looked at with biopsies, it is impossible to say if there are histological correlates for that. But I think personally it's very encouraging to say that you don't lose, you have no decrease of HPV positivity rates, because if you had just diagnostic noise or false positive cases, which is I think the aim of your question, you should normally expect that you would have a decrease of the HPV rate. For the high SIL rates, that's for the moment, after 6 months, we remain the same. But obviously also Luxembourg has a very small population of, let's say, 200,000 women in the target population. And it could be that the 6 months are not sufficient to see any change in these detection rates. So I think we have to wait for more time to see what happens with that. For the moment, I don't, let's say, am I happy with that? Yes, I am, or at least I don't think it's a negative point that we have an increase in low SIL and ASCUS. I would be very disturbed by a decrease in the positivity rate for HPV, but for the moment this is not the case. So for the moment, after 6 months, I think this is a very good result. Thank you. No, we don't. We have cytology, and then the triage is HPV. So that's.
Thank you very much for very nice presentations. I'm Christer Borgfeldt, Lund University. May I ask you, since you now are using this digital part, or have you thought of using dual staining P16, Ki67 to reduce the false positive rates? And have you also tried to implement artificial intelligence? So there are two questions to both of you.
Yes. So in my lab, there's just the cytology part that is done. The P16 test on histology specimens is done in the pathology lab, in the histopathology lab. So I'm just talking for the cytology part. We did the Syntec Plus test in conventional times a long time ago. For practical reasons, we don't use it now anymore.
Yes, in our case, yes, we are using Syntec Plus. We are using P16 also, and because there are some special cases in the follow-up of patients, for instance, where we found high-grade lesions in cytology with positive HPV testing, but gynecologists do not find anything. In these cases, we try to add, so it's not in a general way, but in some very complicated cases, P16 is helping us a lot. Yes, we are integrating. But we are only doing right now manual reading because we need a validated system for in order to read. And it is true that some artificial intelligence, deep learning tools are coming, but we need to validate them.
Thanks. Thank you for your presentations. Enjoyed them immensely. Question to Dr. Rojo, or maybe the panel. Do you think there's a role for digital AI cytology in retrospective review, if you like, of interval cancer cases for audit purposes, maybe particularly in eliminating hindsight bias?
If I understood well the questions, you mean to review previous cases that...
Yeah, one of the pitfalls that we have in interval cancer audits is hindsight bias by knowing that there is a cancer. Do you think digital AI could be developed enough to review those cases and eliminate that bias?
Yeah. Yes, in fact, it is... the answer is yes, it makes sense because the sensitivity and the specificity that has been demonstrated is the same as manual readings with much less effort. The issue is you need to dedicate then a scanner for this review. And it increases the price of the screening program, but technologically and from the results, yes, the results could be very good, but with increasing the price of this reviewing. No?
Are there any other questions?
Hi, two questions for Drs. Rojo and Fischer. Question one is, with the experience, especially in Croatia, we have a lot of conventional labs, and then transitioning to liquid-based cytology always was a bit of a problem with bloody smears. And then initially popular was the glacial acidic acid treatment, but we then had problems with the typical and the cervical cells. The question is, do you use sometimes treatment for bloody slides, and if so, does it have any end result for when the slides are being diagnosed with digital? That's the first question. And second question is, In general, when we say digital cytology, we are mostly focused on gynae cytology, but as it's a sort of a cytology-based question, when saying digital cytology, can you imagine that in 5 years we will also mean the non-gynecological aspirational cytology, so your FNAs, urines, etc.?
Thank you for your question. We do not use, we tried it to have, for instance, with this cytolit, to have a reduction of hemorrhagic slides, but this does not function very well, especially not in a setting where you have 800 slides a day coming, and we do not anymore do this technique, because in our mind it does not help us to change the issue of these cases. A lot of these cases you can nevertheless put a diagnosis on them, even if they are hemorrhagic. So that's the answer to the first question. The second question, sorry. Non-gynae, yes, it is obviously in the intention to do also non-gynae with the system. For the moment, I think the system works very well for anal cytology. It works very well also for urine cytology, and I think for lung or thyroid cytology, things are coming.
Yeah, in non-gynae cytology, we are not using a scanning system. We are not using the distributed model because to us it's like frozen sections. You need to do it locally. Here it's more important the communication between and also time is very important. So our response times is 1 or 2 days, and it will not be possible to have the same response times in this distributed and having a reference center. So in order to improve this and in order to foster the communications between pathologists and clinicians and the rest of clinicians, we are not using this distributed model, and we are not using digital cytology.
Just out of curiosity question, Just out of curiosity question, for non-gynae samples, do you use Papa Nicolau staining only, or also Giemsa as well?
Well, it depends on the organs.
Yeah.
Papa Nicolau, most of them, but in some cases, for instance, if we talk about 5 needle biopsies, then you need much other stainers. But normally Papa Nicolau, yes.
So I would just like to don't leave you under the impression, because Dr. Fischer cited this blood paper that had a lot of discussions already in the literature with this large number of HPV negative cancers. If that would be the case, actually, that was actually a retrospective study with serial flaws in the design. But if that would be the case, we would see much more interval cancers in the UK pilot, which is not the case. And me and my colleague Uli Petri have also published a few years ago where we investigated 371 of those so-called negative cancers, and most of them were actually histopathology, no cervical cancer, and only one remaining HPV negative out of them was clear cell, very strange type of cancer actually. So just to leave you with this comment from my side.
Okay, so it's about time to close the session now. I think it has been quite re-interesting in the cytology field and the imaging field, coming to the rescue of some of the screening issues. I think it's time to congratulate the work that has been done so far, and that has brought a new test to the confirm and established test amenable for screening programs. That is good news. And I will thank you, the speakers and the audience, for being here today. Thank you.